The first thing to do is to try to remain, the most important lesson I could teach you, more than any of the content on my website, is just to try to keep calm on the exam. You'll notice that you'll do a lot better if you can keep calm. And if there are some questions where, there's test questions, they're pilot questions, they're not real questions. They're just there so that they can test if it's a fair question for next year. Usually those are pretty hard or on weird subjects. So for those questions, just take 7 deep breaths, because 7 is the target A1C. So just take 7 deep breaths, you'll feel better. And, because you want to read the question slowly and not panic. And if there is a question that, oh my God, it's really freaking me out, I don't know the answer to, just skip it. It could be one of those pilot questions. And most importantly, those pilot questions aren't worth any marks. Even if you get it right, you get 0 marks. So to panic over it is like not a good deal for you.
I'm assuming we all have different tests, because like I'm thinking about when I leave, if I got questions, I'm thinking we're all going to have different tests probably, so it won't matter to go and ask what the answer was to whatever.
So you all have the same questions, but the order is scrambled. Well, I'm not sure. That's the way they used to do it when it was in person, because then you couldn't see the Scantron of the person next to you if their question 5 is different from your question 5. So. But if they're doing it through Top Hat, I don't know what they'll do. Maybe we will have the exact same test. I don't know. But the test is the same for everyone. So there's no for Ontario, is this covered by the Ontario Blue Cross, or in BC, is this covered by the BC Blue Cross? There's no questions like that because it's a national exam. Okay, so it's 5 o'clock now, so we'll get started. I've got 2 questions here from Kim and Brittany, and one from Latoya. Are Kim and Brittany here? If so, I'll answer their questions first. This is just meant to be a very casual Q&A. It's not formal like Dr. Peterson's yesterday. If you do have any questions, you can just type it in the chat here, and then I'll just go from first to I'll just go in the chat and answer your questions. Yeah. So first, because Kim, oh, here's Kim. Kim is coming in. Is Brittany here? Hi, Kim. How are you doing? You asked this question, right, about the Levemir and stuff like that?
No, it wasn't me.
Oh, that wasn't you? Oh, must be
nope.
different. Sorry.
Kim, I think.
Okay. Kim is a common name, I guess, but.
That's right, it is.
Okay, so yeah, Kim, I'll wait for Kim and Brittany to come in to answer these questions. But yeah, you guys can just start entering questions in the chat, and I'll help answer them and get you as ready as much as possible for tomorrow. Okay, perfect. So here, let me copy and paste this from Miriam. I just want to copy paste this. Okay, here. There's too many. I have to admit people in as we're talking. Okay, so Miriam asks, I was wondering about the age consideration for dose of CV risk factors and medication. In the table it says 60, but in the summary of recommendations it says 60 and above. Can you clarify? Okay, interesting. So let's take a look. So you're talking about primary prevention, right? Miriam? So here it says age 60 years or older, and then oh, I have to admit Sally. And then for those CV, the table says above. Which table are you talking about, Miriam? If you're chatting, I can't see it because I'm. If you can unmute yourself.
Hi, Esmond. This is Miriam.
Hello, Miriam.
It's in the colorful table with, CKD, HHF.
Okay, this one right here, right?
The one above, yeah, there.
Oh, you're right.
Above 60, yeah.
That's annoying. So
Yeah.
I think if you've found a discrepancy in the guidelines, I'll email them about it, but they never answer me back. I'd always go, let me see here. I'd always go with what the recommendations say because that's in gray, whereas the table is, this kind of stuff shouldn't happen. Someone in proofreading should have caught it. But I would go with this one. If it's on the exam, I'd go with the 60 or above because it says it right here.
Thank you.
Yeah, that's a good catch though. You caught them. I'll email them about it. I'll give them a heck about that.
Thank you so much.
No problem. Okay, Joy. Hi. Here, let me just copy and paste this. So that everyone can see the question. Hi, Esmond. I'm wondering, you could explain the etiology of chronic liver disease decreasing A1C. I was going through the tables and realized that the factor listed was erythropoiesis. Used to think it's related to glycation. That's a good question. I would assume that it has something to do with, here, let me just see here, decreasing A1C. I assume it's because the liver and the bone marrow are extensively needed to create red blood cells or stable red blood cells. And if the blood cells aren't stable, then if they're deformed, just kind of like sickle cell anemia, if they're deformed and stuff like that, they don't last enough to circulate, go around in the blood and collect sugar. Kind of like that donut idea that I explained, where your red blood cells, as they flow through your blood, they collect sugar, so they kind of collect this coating of sugar, that's that glycated A1C, and that's what they're measuring with the A1C. So anything that affects the shape of the donut or makes the donut break easier will affect how much sugar coating is on it. I'd have to look that up. After the Q&A, I could try to look it up more, but that's how I would assume that it's done. It's because that red blood cells are just not as structurally sound and they collapse easier. Yeah, does that answer your question, Joy?
Hi, this is Joy. I was just confused because I thought anemia.
Sorry, we can barely, you're like a whisper.
Oh, sorry.
Let me try increasing the volume. Yeah, does that answer your question, Joy?
Is this better? Can you hear me better?
Oh yes, well, that's much better.
Okay, sorry. I was just saying, I thought chronic liver disease is like it causes anemia, which would falsely elevate A1C.
That is right, because anemia, the cells you want to hang on to the iron for longer, and then
Right.
that's a good.
And how I understood, like how I remembered chronic liver disease was associated with decreased A1C was I thought it's like the liver was busy with some other stuff or it's damaged, so it can't do proper glycation.
No, I don't
Like
think
there's
that. Like the glycation is just from the glucose interacting with the hemoglobin as it swims around in the red blood cell.
sorry. What? Oh, sorry. I meant like making glycogen. I meant. So there's more like the liver was damaged, so there couldn't you couldn't convert the sugar into glycogen, which left more sugar hanging around your blood, which caused like.
I don't think that's how it works because. Like so your liver is like this alchemist in your body. It's the primary. It converts glycogen into glucose, but the glycation from the hemoglobin A1C, it's from like the iron interacting with the sugar, kind of like almost like rust over time when it swims around in your blood. That's why, like, if you're diabetic and or you have diabetes and you get like a blood transfusion right before your A1C, then your A1C will be normal because all the red blood cells are from the donor who doesn't have
Which wasn't in contact with the sugar, right?
Yeah. So I'll have to look that up more, but off the top of my head, I don't know the exact etiology. I assume it's because the liver is not making structurally sound red blood cells.
Oh, okay, thanks.
Yeah. Okay, next question. 15 grams, Noor asked 15 grams of carbohydrates. equal to 175 ml of juice, or soft drinks 150 or 125 mils. So the standard treatment of hypoglycemia is 15 grams. I do have a cheat sheet here under, so you should use the latest Beyond the Basics guide for it. So that's just right here. And you can see half a cup of juice is 15 grams of carbs. And so 250 divided by, so 125 mils. Yeah. Okay, so Karina's asking, here, let me paste this so that you guys can see all the questions. Okay, so when starting someone on MDI, you split the insulin 60-40 and divide the 60 into 3 meals. What do you do if the patient only has 3 meals? Do you just omit the third 20%, or do you split the 60% into 2 doses of 30? Oh, that's a great question, Karina. Yeah, just not everyone has 3 meals a day. Intermittent fasting is getting more and more popular. So people are having like 2 meals a day or even 1 meal a day. I don't think there's an official answer for this. You would use your clinical judgment, but assuming that they're having their full amount of carbohydrates and full amount of protein and stuff like that, I'd probably just split it 30-30 just to make it easy. If you feel that they're like malnourished or they're not eating a lot, then you could just omit that other 20%. But I think it would just, like, you want to try to keep that, because your normal, like if you don't have diabetes, they've measured it so that, you know, most of your insulin is secreted with meals. That's why that you've got that 60-40 ratio. So you would try to want to keep that 60-40 ratio as much as possible. Yeah. So yeah, I would probably just split it 30-30. Okay. Oh, Miriam says in the hypo chapter, it says specifically 150 mils. Oh, that's interesting. Let's look at that chapter. Oh, it does say 150 ml of juice or regular soft drink. So you guys have found another discrepancy in the guidelines. Here, I better start writing these down actually. And I will complain to the Diabetes Canada guidelines on your behalf, but usually they don't do anything. So the 150 mils, and then the age of 60. Okay. Wonderful. Yes, that is confusing. Like, people should, I don't know, people should proofread their guidelines, because we are trying to follow them to the letter. And when they have those little discrepancies, it makes it confusing. For the exam purposes, are we okay to say 125? For exam purposes, because this says 150, I would actually use 150. So I'm writing the exam tomorrow too. I would say, so if a question is asking about hypoglycemia, I would say 150. If it's like a nutrition question, it's asking how much carbs is in 125 of juice, then I would use that 15. I know that's confusing, but that's probably how the exam writers will do it. Okay. Okay, perfect. Is Brittany or Joy the one that asked me these original questions? Are you guys online yet? Okay. Anybody else have any questions? Okay, maybe Dr. Peterson answered most of them yesterday.
Esmond, I just had a question.
Yeah, for sure.
Why is the targets different for the glucose tolerance tests with the preferred method as opposed to the alternate method?
Okay, so first of all, I want to preface that with, I have no experience in gestational diabetes. In Calgary, most of that is, like all of that is handled by the Diabetes and Pregnancy Clinic. So I don't have any experience with gestational diabetes. The reason why the pregnancy chapter is kind of so confusing is because there's still that's still an area of active research. That's why like when something's for sure, you can say, okay, aim for 7%. But when something's under active research and you don't really know the answer, then you say, okay, well, with this method, we did it this way. With this method, we did it this way. And with this method, we did it this way. And so that's why there's so many like alternate methods and stuff like that in the diabetes and pregnancy chapter. It's because they don't really have a standard way of doing things currently. Yeah, I hope that answers your question, but I don't really have an answer for that one.
Thank you, Esmond. I just found it confusing trying to memorize the two different values for, yeah.
Mm-hmm. It is confusing and it is annoying because, you know, I have to memorize it too, but it's just like, it's harder, you know, to do diabetes research for pregnant people. It's just harder to do it than regular people. So there's not as much research. It's still, they're still building up that research basically. They haven't figured out which one's better. Okay. Okay, Joy says, yeah, in real life, different types of juice have different sugar content. So it is just a rough guideline. Noah asked, is there a calculator? There's a built-in one with Top Hat. Yes, you can, all the test exams, you can just try them out. They don't have any real questions on them. It's like, who's the president, who's the prime minister of Canada, how many seasons there are in Canada. So you can familiarize yourself in the function. Is amylin an anabolic hormone? That is a good question. I don't believe it is. I think it's similar to like GLP-1s. It doesn't make you gain, I don't think it makes you gain weight. It just regulates appetite and stuff like that. So I don't like, and the thing is amylin, the medication that stimulates amylin, it's not available in Canada anyway. It's in the States. It might come over to Canada, so I doubt it'll show up on exam. But I would say amylin's not a anabolic hormone, just like how you would say GLP-1s are not anabolic. Why is lowest BG 3.7 in pregnancy? I'm not sure why. That's just what the studies show. Seems to be awfully tough on pregnant women though. Like I've looked at that and said, geez, that's kind of rough for pregnant women. Like they have diabetes already and now you're trying to get them so tight. Like, you know, I have some friends who have like type 1 and type 2 diabetes and it's tough to get it down that low and not have lows. Okay, can I get the targets for A1C for pre-pregnant and pregnancy? I'm thinking I can get A1C. Okay, so Jerry, if you look at my cheat sheets, I have one on targets right here. And if you take a close look, it has pregnant women here and preconception A1C here. Okay, good. Yeah, so the targets are right here, if that's what you're looking for. Nora asks, let me copy this. Nora asks, just a clinical question, if a patient has metabolic decompensation and they based on Basaglar, does it make sense to start metformin at the same time? C-peptide testing has not been completed yet. I would say it does. Well, okay, do you think that, okay, so Nora, do you think that they're type 1 or type 2? Are they like really thin and young, or are they kind of old and more obese?
They're older, but I just actually had this patient case today, so
Okay.
I was just curious your opinion. So the patient was, I believe, 59, and recently over the last 2 months, he's lost about 30 pounds. The patient today the doctor today started him on Basaglar 10 units at bedtime and metformin twice a day. And he still hasn't had testing for peptide testing or the
GAD and anti-islet.
Exactly, yeah, not yet. So he's going for that next week. Okay. So I just was curious if it's okay to start him on both.
Sure. So that's a really good question, and we'll take this as a kind of like a case. So if you suspect that the person is type 1, like if it's like a kid or something like that, then I wouldn't start metformin. And yeah, and I wouldn't start to metformin. Like metformin doesn't harm people with type 1 diabetes. There are some endocrinologists that actually use metformin in people with type 1 diabetes just to improve the insulin sensitivity. So it's not like it's harmful to start a type 1 on metformin. Now it is contraindicated, so you have to be careful because it's, you know, it's not an indication. But there's like no, like, there's like from a legal perspective you're not supposed to, but from a clinical perspective there's no harm. So if it's a type 1, then I wouldn't start them on. If I thought for sure it was a type 1, I wouldn't start them on metformin. For type 2, I think it is perfectly fine to start them on metformin. The metformin will reduce the amount of insulin they need anyway, and it'll curb the amount of weight gain that they'll gain from the insulin. So I think it's perfectly reasonable, especially if it's an older, more overweight individual, to just start them on the metformin right away.
Thank you so much.
No problem. Okay. Cherry says, oh, sorry, my dog wanted to get out and I didn't get answer, but the diff before pregnancy and after they were pregnant. So pre-conception, we want them to be 7 or less if possible. And then once they're pregnant, we would like them to be 6.5 or less if possible. Even more strict if safe and they have no hypos. Yeah.
I'm sorry, the question I think I'm getting mixed up is because I've done that many tests that my head is just spinning. I'm thinking it's, like you said, but the one for when they're pregnant, is that for anyone who's pregnant with gestational diabetes or just the people who were diabetic before they got pregnant?
That's for any person with
okay, thank you.
Yeah. Good. Wonderful. Can we briefly review HHS and DKA? So we can, definitely. And there probably will be 1 or 2 questions on exam, but there's a lot from that chapter that you don't have to memorize. Like what chapter is that? Like the whole protocol and using like IV saline and potassium and stuff like that. I've never seen that on the exam before. And to be honest, I think everyone would get it wrong except for like emergency physicians. Here we go, hyperglycemic emergencies, 109. So, where is it? So what is important from this chapter? Let me just get there. Okay, perfect. So what is important in this chapter? I think it's important to know to be able to differentiate DKA and HHS. The biggest thing that HDKA has that HHS doesn't have is ketoacidosis. There will be minimum ketones in HHS, and there will be minimal acidosis in HHS. So that's how you can tell the two apart. Typically, DKA happens with type 1 because there's a complete absence of insulin, and HHS is more common in type 2 because in people with type 2, they still have a residual beta cell function, and so they are producing a little bit of insulin, so that prevents it from going to DKA. As long as you have a little bit of insulin, because your brain wants to use sugar as energy, only when it's desperate, it will break down fats into ketones. As long as you have a little bit of insulin, then you won't go into DKA because the brain will still be able to use some glucose. Some other important things to know from the chapter are for children, you always use fluids first because kids can get what's called cerebral edema. And cerebral edema is when the brain swells, and in children that can actually be fatal because in adults, we have lots of room in our heads apparently. Oh, there's people I need to admit. Apparently we have a lot of room in our head. So if our brain swells, there's room for it to expand. But in children, they're growing, and so they don't have a lot of room in their heads. So if the brain swells, then their skull crushes their brain, and that's incompatible with life. So that's why you always give fluids first in children. I think it's also important to know that SGLT2s have this weird euglycemia DKA. We don't exactly know what causes it. We know that SGLT2s increase glucagon, and maybe that opposes the insulin, turning it into DKA. But that's just a weird side effect that you need to be aware of. Normally, if you're drinking lots of water and keeping well hydrated, you don't get that euglycemic DKA with SGLT2s. Yeah. Does that answer people's questions on that chapter? Okay. So Carolina asks, people who hates blood glucose, which is the minimum interval for type 1 and type 2? Sure. So there's a chapter on that. I don't think it matters whether they have type 1 or type 2. Let me just get back to this. And that's, who's asking that? Carolina. Okay, let me just admit some people from the waiting room. So I don't think it matters whether they're type 1 or type 2, but there is an appendix back down here that shows the minimum amount of monitoring. Is that what you were talking about, Carolina? Yeah, so the minimum is just right here. It's irregardless of type 1 or type 2. Okay, so Nora asks, I'm a bit confused about the carbs for different items. For instance, one slice of bread I found to be 15, 12, and 11. Which one should we stick with? That is a good question, because if you look in different places, you'll find different answers. For the test, I would use this one right here. Because this is the latest one, it's from the latest Beyond the Basics chapter. You know, different websites, different places will all have different numbers, but this is the one I would stick with for the exam. And this is the one I'm studying for the exam. Okay, Nora asks, if a patient is on, here, let me copy and paste this first. If a patient is on basal insulin only and oral medications and is not a target, what is the minimum amount of self-monitoring blood glucose they need to do? Well, at least one, because they're on basal insulin. And then if you look here, it would say, you know, if they're not meeting glycemic targets, then at least 2 times per day. Okay, Karina, yeah, one slice is generally 15 grams. That's what I would memorize for the exam. One slice of bread is roughly 15 grams of carbohydrates, whether it's whole wheat or whether it's white bread or whatever. One slice is generally 15 grams. Okay, Caroline asks, for Ramadan, if a person decides to go ahead and fast, even though it is contraindicated, what recommendation can we give? So if we want them to not fast and they still go with it, I would try to reduce their medications a little bit so that they make sure that they don't have a low. I'd remind them that as per the diabetes guidelines and the International Diabetes Federation, that as someone with diabetes, like someone who has a medical condition, they are exempted from fasting from the rules, as I understand it. So I would tell them to, I would try to reduce their medications if possible. And number 2, I would try to have them to keep some fast-acting carbohydrate on hand, and to, again, tell them that, hey, if you have any medical emergencies, it is permissible as per those guidelines to break your fast. Yeah. Okay. There's some thanks, Karina. Yes. 15 grams. Yep. Just as Karina says, I would use 15 grams. Be mindful of the carbohydrate, though. Yes. The legacy effect. Okay, so Sally is asking about the legacy effect. That's a good question. I think I have a new. So here, let me go to the cheat sheet for that. Okay, so the legacy effect. So when the UKPDS and the DCCT were both landmark trials, they both lasted about 10 years, and they found that the lowered A1C with the intensive group, the lowered A1C group, that there were benefits. So the legacy, you had these people. They were split into two groups. Like I don't remember the exact numbers, but one group was like at 9, and the other one had a target of 7. The conventional group had 9, and the intensive group had 7 as their target. So here they go for 10 years, and now after 10 years, they get kicked out of the study. After the study, those two groups, the intensive arm at 7% and the regular placebo arm at 9%, eventually they came together to about 8%. Who know, like maybe the people in the 9% group saw that, hey, these people in the 7% group are not losing their toes and they're keeping their eyesight. So I want to improve my sugars. And then for the 7% group, if maybe once they're kicked out of the study, then they don't see their CDE anymore, and maybe they get more lax with their diet and stuff like that. But eventually the 7% and the 9% group came together. Then 10 years afterwards, okay, so 10 years after that, they're both at 8%. But then they did a follow-up and they found that, hey, everybody's at 8%, but the people who were in the 7% group are still having less heart attacks, less complications, less, et cetera, and the people at the 9% group are having still more heart attacks and more complications, even though they've both been at around 8% for 10 years since being kicked out of the study. So then they called that the legacy effect, because the legacy of keeping your sugars down lasts for a long time. Even though your A1C went up to 8 for 10 years, you still had less complications than the people who are at 9. So that's why they want everyone to try to get your A1C down to 7 as much as possible. Does that answer your question, Sally?
I'm just wondering what kind of questions I should expect for the legacy effect.
What kind of questions? It could be something like, a patient is wondering, why do you want to get your sugars down? Why do you want to get my sugars down so quickly? My sugars are going to go up to later, so why is it so important to get my sugars down now? You could say, well, the UKPDS showed that with this legacy effect, if you get your sugars down to target faster and keep it there for faster, you get benefits even though your A1C rises later. Maybe some kind of question like that.
Okay, can I also ask about the other study? It wasn't in the cheat sheet, it's called the veterans.
Oh, the VADT?
Yeah.
I didn't study that question. I didn't take a look at that study for the exam, so I'm not familiar with it right now. I doubt that. I don't think it'll show up for the exam.
I think there was one question on the essentials.
One question on the essentials. Okay.
Yeah.
I don't have that study. If you do have a particular question, you can put it in exam form, and I might be able to get to it tonight. But I'm also writing tomorrow too, so
yeah, I
know. Yeah, but does that legacy effect kind of make sense?
Yeah, I think there was one in your exam sample exam, but I can't remember what was the question.
It was probably about I remember creating question, but it was probably something like patients asking why the legacy effect is important or something like that. You just need to know that if you get your sugars down faster, you get benefits later, is the bottom line. Okay. So Nora asks, beta blockers cause hypoglycemia or mask symptoms of hypoglycemia? That's a great question, Nora. So let me just paste it here. Okay. So they mask symptoms of hypoglycemia. Okay, so think about it this way. When you're having a low blood sugar, when you're having hypoglycemia, your body is secreting things like glucagon. It's secreting things like adrenaline. Glucagon and adrenaline help raise your blood sugar so that you're not low. Beta blockers, or their full name beta adrenergic blockers, block epinephrine. So your body's creating all this epinephrine to make you feel anxious, to make you feel unwell, to signal to you that you're having hypoglycemia. But those beta blockers are blocking those epinephrine signals so that you don't feel it. So beta blockers, they don't cause hypoglycemia. They don't cause your sugars to go up or down, but they mask the symptoms of hypoglycemia. And that's kind of controversial. Like in the 2008 guidelines, they mentioned it, but then in the 2013 guidelines, they actually took it out. But then in the 2018 guidelines, they put it back in. So I think they're still on the fence about how much of a masking that is. But for the exam, definitely I would say that it masks hypoglycemia, but it doesn't cause hypoglycemia. Yeah. Okay. Yeah, tight control equals less complications. This is a definition of the legacy effect. Yes, that's what it was. Okay, perfect. And that's the end of the questions. Anyone else have anything they want to chat about? We still have 24 more minutes. Actually, here, glucagon. Okay, perfect. What's your glucagon question, Carolina? I'm just going to turn on the lights. It's getting dark here in Calgary. Can you please explain the dose, like for children or for adults? Okay, so this is a common question I'm getting about the dosing for children. Let's see here.
I think why you're getting it is because in the essentials binder, one of the questions was saying to give 20 micrograms per age, and the other material said different.
Oh, so definitely I'd go with whatever the guidelines say. It is, let me find it. I believe it's 10, actually, hold on. Everyone's been asking that in the exam form, actually. So let me just go here. Here we go. Okay. So it should be 10 per age, with 20 being the minimum and 150 being the maximum. And then you can double that after 20 minutes if the BGs are still in the hypo range. When it says 150 maximum, that's per dose, because you can use like 0.5 or 1 milligram, which is 500 to 1,000 micrograms if necessary. So yeah. Does that answer your question, Carolina? You asked glucagon, yeah, explain the dose. So that's the dosing in children. Okay, Marva asked the difference between insulin analogs and mixed insulins. Okay, this one is, okay. So this is in one of my video presentations, I believe. So insulin analog, you have for the amino acid chain in insulin, like Humulin R has the exact same insulin chain as the insulin that you're producing with your body right now. Insulin analogs, oh, Sally, you put your hand up. Do you have a question? I'll ask you to unmute.
Ask after you're done with your answer.
Oh, sure, okay.
It's a different subject.
Oh, it's a different, okay, just put it in, we can put it in the chat too.
It's easier to say, that's why I raised my hand.
Okay, perfect. Okay, so I'll get you. Where was I? Oh yeah, insulin analogs. Okay, so insulin analogs are when they've changed that amino acid structure. So for example, for NovaRapid, they made it so that insulin normally forms hexamers, and that makes it stable. For NovaRapid, they made it so that those hexamers break apart really quickly. So that's why that one's rapid acting. for things like Levemir, Atlantis, we made it so those hexamers stick together for longer, and that makes it longer acting. So that's the differences between insulin and an insulin analog. Insulin analogs have their amino acid structure changed. So between mixed insulin analogs and mixed insulin. Okay, so the old insulins, here, let me just go to the chapter. So the old insulins are Humulin R, so the exact same amino acid structure as the amino acids as the insulin you're producing with your pancreas right now, and they mixed in protamine. Protamine stabilizes those hexamers to make it last longer. So it is like for those older insulins like Humulin 3070, it's Humulin R30 and then basically NPH for the other 70. Because NPH is just protamine mixed with Humulin R. That makes NPH. You can think of it as Humulin R, which is your normal human insulin. Then when you mix protamine into it, it turns into Humulin N. Now, the difference between these ones here and these newer premixed insulin analogs are that these ones are made with NovoRapid, and then they put in the protamine. So basically, you have, with these ones, you can take it, these ones you still have to take 30 minutes before meals, because the R you have to take 30 minutes before meals. These ones you can take right at meals. And then they both have a similar NPH peak. But the benefits of these, because they're analogs, they usually have less hypoglycemia, and you can take them right before the meal instead of half an hour before, which is much less convenient. Okay, let's see here. So, there's a whole bunch of questions still. Here, let me answer Doris. I think Doris was before you put up your hand, Sally. So let me answer Doris's questions, and then I'll get to you, Sally. So will there be questions on oral semaglutide and nasal glucagon? I suppose so. Those came before February 1st, 2021, Doris. Oh, actually, let me copy this first so that people can see it. Okay. Yeah, so it's possible that they could show up. I don't think that they would make a big difference, though. They're very dose is similar to injectable glucagon, semaglutide. Like, you don't have to worry about doses or something like that. So yeah, I think they could be on exam, but I don't think there's anything really different about them. Okay, so Sally, what's your question?
One of the questions was mentioned on the practice exams about a patient that he's 65 and he has a limited pension. And like the questions is leading you to pick the pre-mixed, but you put in the explanation of the answer that you should consider the national question, but don't think about your province. Because Correct. In Ontario, he's 65, he will get both the Apidra and the Lantus or Tresiba for free. So would be some questions like that like it will be different from province to the other. Should I consider that he's...
No, so the thing is that it's a national exam, and so you can't assume that, oh, like in my province, Apidra is covered, so I'm going to pick Apidra because it's covered in Ontario. Or in Alberta, oh, if I get special authorization, I can get Ozempic covered, so I should just choose Ozempic because Alberta Blue Cross will cover it. So you can't assume that they're on any provincial drug plan. Basically, they have no drug plan or they're on some sort of private drug plan. But don't assume that they're on your province's drug plan because it's a national exam. Everyone's questions from BC to Newfoundland are exactly the same.
So seniors that have different coverage in different provinces, that's what you're saying, right?
Correct. So you can't assume that they have the same coverage in your province. Like you have to assume, oh, this question's from BC or something like that. I don't know if Apidra is covered or something like that. Or like in Alberta, I can get Jardians covered through special authorization, but I can't assume that they're in Alberta. They're just in some limbo province somewhere that doesn't have any provincial drug plan.
Okay.
Does that make sense? Like, don't assume that they're covered under.
It just,
Yeah.
I wouldn't like, I wouldn't even think about it till you put this in the explanation. That don't think, forget about your province, just answer nationally. Because I wouldn't think twice. Epidural lentis is always covered. So why I don't offer the good option, not the cheaper option, because he's 65, or they just use another age that wouldn't cause the problem.
Yeah. No, this came up because because like people from different provinces use my website. So they've run into problems where, oh, well, in Ontario, we have full coverage of blah, blah, blah. So that's the answer. But in Alberta, no, we don't have full coverage of that. So that's not the right answer, because the answer for the exam is the same for everyone in every province.
Yeah, so we should consider, like, when they're leading, that there's always a limit in the cost to go to the pre-mixed.
Oh, or whatever's like there's a money sign thing here. You don't have to know the exact price. You just have to know that some things are more expensive than others. Yeah. Okay. So next question, 10 milligrams, 20 milligrams. Yep, thank you. Oh yeah, you can't microdose the nasal. That is true. So that is something different. If they're using Baqsimi, then you can't microdose it. But otherwise, the dose is similar. Miriam, that's a great point. If someone has a hypoglycemic, here, let me see here. Let me just paste this. Someone has a hypoglycemic event, and his blood pressure was too high right after. Could that be a reaction? Yeah, like your body's under a lot of stress when it's under a hypoglycemic event. And remember, your body's pumping out adrenaline to try to get you out of that low. And so the adrenaline could be spiking your blood pressure, and once you remove the hypoglycemia, your body will reduce the adrenaline. So I think that'd be a reaction to a hypoglycemic event. Tijani, what's your question?
My question was about that sample question, like that they sent. So they talked about that lady that's she's a cop, she's a policeman, and her A1C was 9.1, if I remember. Mm-hmm. And the options that were, yeah. So like for my answer, when I was like looking at all those, I know that we have to kind of like cut 20% and whatnot, so you can have it, so she can have like a better. But at the same time, when you look at that A1C, wouldn't like your mind just go straight to thinking, you know what, she might need more insulin? Or is it like, how do they think that our brain thinks just about cutting that insulin by 20%, knowing that they're like, how would you, like, are you really advising them a good advice or what? Because I was just like, that was a very bad question, actually, the way it was worded, I guess. I don't know.
Yeah, I feel that like, you're absolutely right. I 100% understand, like, with you. It's just from experience from the exam, because I've written it a couple of times, that it's always reduced when you are going from twice daily to once daily. And you're absolutely right. And
because I would think they should not even put the A1C, just say, hey, this person is this, now we want to kind of like, they want to go to different things, and we can be fine. But when you put an information that's crucial in making your decision, like you're just throwing me off, like to pick up something else that does not really make sense at the end of the day.
Yeah,
so
no,
that would be like one of the questions that I will get wrong. Like thinking logically, you'll get it wrong.
No, you're absolutely right. I completely agree with you, Tijani. Like if their A1C was like 7.5 or something like that, and maybe they're having, or maybe if they were having low, it just said, and the police officer is having lows, then maybe that would clue you into, I better reduce it first before increasing it. But yeah, for the exam, because I've just written it a whole bunch of times, it's always reduced by 20%, even if their A1C is high. In real life, I absolutely agree with you. Like if I had like a Libre handout and it showed that she was high all the time and if she was having no lows, you know, I would probably increase it, just like you mentioned. Or if their A1C was like 15 or something like that, and I'm switching, like, and I knew they were having no, like but there's something to remember though, having a high A1C does not guarantee that they're having no lows. That is really important to remember. My worst patients, they're my worst patients are probably young adult type 1s. Their A1C is like 10, but they're having daily lows because their sugars are just up and down, up and up, up and down. So just because they have a high A1C doesn't guarantee that they're not having any lows. But I totally agree with you. Like if I had some Libra handout that showed that they weren't having lows, their sugars were high all the time, I'd be increasing that, not decreasing it. So in real life, that's just something to consider. But for the exam, I would just say, in that one situation, I just always say reduce. Yeah, hope that answers your question.
Thanks.
Okay. Rebecca says, let's see here. Oopsies. Let me just copy this. I noticed there are different sort of recommendations for treating hypo with juice. Yeah, that's come up before too. You're not, I've emailed the guideline committee about that a whole bunch of times that, hey, do you have some inconsistent amounts everywhere? But they have not emailed me back about that. So unfortunately, just pick one of them and hopefully that's the one that the question creator was looking at when they created the question. Okay, what are the doses for intraness of glucagon? Yeah, I believe for Bascini, there's just 1 and 0.5. Oh, sorry, 3 indicated. Okay, perfect. When we switch to Toujeo, we decrease 20% or the other way around. This came out before. Like I don't use Toujeo a lot, but let's take a look at the product monograph. One sec. Because they took it out for a while and then they put it back in. So let's see. Toujeo is not covered out in Alberta, so that's why I rarely use it. I think I have like, I'm not sure if I even have a single patient on it. Why isn't this working? Come on, government website. There we go. Let's see. Okay, let's look at the dosage. Oops. So what page are we on? Page 20. Okay. I believe it's 20% when. Yeah, here we go. Not directly interchangeable. So switching from once daily basal insulins to Toujeo, just starting dose can be the same, okay? But same thing, switching twice daily to once daily should be reducing by 80%. I did see some, this came out somewhere else. I can't remember where. Maybe it was in last year's Q&A or somewhere in my exam form. There was something that said, when you're switching from Toujeo to something else, you reduce the Toujeo by 20% as well. The problem with Toujeo is that because it's so concentrated, it's kind of like, think of it as like a tightly bound ball of yarn. And then it's kind of slowly dissociates. That's how it lasts so long because it's so concentrated. But the problem with doing that is sometimes the inside of the ball, it degrades. And so usually I have to use, like, if someone's on like 100 Tresiba, or like 100 Lantus, I have to put them on like 120 of Toujeo to have the same effect. And all patients hate being on more insulin. Like it's just a numerical thing. Any time where you have to increase the number, they feel bad about it and they get upset and angry about it. So that's kind of another reason why I rarely use Toujeo. Just try looking in my exam form under medications last year. I believe someone talked about reducing it by, the answer is there somewhere. I remember answering this question. So it's just in the exam form. Okay, so hope that answers your question, Sally. For type 1 diabetes, do you consider ketone testing when blood sugars are above 14? Not here, let me see. Not usually. Like for exercise, there is a point where you don't want them to exercise if their sugars are that high. But you don't have, like, I don't think it mentions anywhere in the guidelines. So if someone can correct me, I'm totally okay with that. But I don't usually consider ketone testing if sugars are above 14 unless they have some other, like they're feeling sick or they're having other symptoms of DKA. Because again, my patients with type 1, my poorly controlled ones with type 1, they'd be testing their ketones like all the time if that were the case. Oh, sorry, I keep forgetting to copy. You can't see my chat, so I keep forgetting to paste these questions. 1 second, sorry about that. So that's from Noor. Can you briefly discuss somology and Down syndrome? Sure. Actually, a better way to do it would be to look at the exam form. I've already answered that question, but I can talk about it quickly. Somology is when your sugars go low in the middle of the night, and then because of glucagon and epinephrine, it goes high. So you need a low and then a high. And then that's why your sugars are high in the morning, because you had that dip and then it went back up. Dawn is just kind of this natural phenomenon where your sugars are high in the morning because your body produces adrenaline and cortisol to wake you up. Yeah, here it is, right here. Yeah. So that's the difference between them. Tijani, 16 to 17. In real life, no.
Sorry, it was actually an endo doctor at the hospital that, and I don't know if she was talking just in general, but she said like I would worry about those around 16 or 17, but I did not know if it was based on a study or on something or she just said it for that particular patient. So sorry.
No problem. We're all here just to learn and stuff like that. Me included. I would start getting worried at 16 or 17. At that point.
She was talking mainly about the ketones for us to measure. And she mentioned actually the urine ketones. She said like if you see them like around 16 or 17, please do that. And that's how I kept on thinking about it that way.
Okay. Yeah. So that's good to know. I typically don't use urine ketones anymore because with the Libra and the older freestyle meter, you can just do blood ketones, which is much more accurate. Like if their blood sugars are 16 to 17, they probably should start measuring their ketones, but I doubt my type 1s do. So yeah, I do have a good, let me try to find it. I thought I posted it somewhere. I had something on, here, let me see. And again, it's kind of annoying because every health region has their own kind of, actually, I don't think it's on, I can't reach it without logging in. I'll post it in the exam form later, but every region kind of has its own kind of guidelines on ketones. So, but for the exam, you know, I would know like the symptoms of DKA, or know like for exercise, if they're having DKA, if they're having ketones, then you would suggest not exercising, stuff like that. Yeah. Okay. So it's 5:59 in here in Calgary. Maybe I'll answer one last.
Speaking about exercise on the diabetes Canada, it says to advise type 1s if their sugars is 17 and they have ketones not to work out.
Yeah, that's kind of that's a limit. Where is that? Yeah, that's kind of like the limit where they start getting concerned. I believe that's right. Here, yeah. Yeah, it's 17 is, I think, the cutoff where they say, okay, and ketones is where they say, okay, stop exercising. Yeah, right. 16.7 to be exact, but for the test, I'm going to compromise 17. Doris asks, if you have to change TGO to Tresiba or NPH, do you decrease by 20%? Let me just put that here. I don't know what, I would never do TGO to NPH because in Alberta, Levemir is covered, so I would do TGO.
You have to do that because Pacific Blue Cross denied this claim. They decided not to pay for it anymore.
Oh, your province decided not to cover TGO?
Well, what happened? Yeah, what happened here was on Lantis, okay. And so they they decided to not cover Lantis. They want them to go back on. They will pay for NPH, but they won't pay for Lantis or Tagero or Tresiba.
Oh,
unless you want to pay for it.
I see. So TGO to Tresiba, I would decrease it. Yeah, I would. Because
TGO and Tresiba is supposed to be the better insulin, will physiologically be better, and then so we decided to bring them down, knock them down to 20%, then titrate up.
Yeah, that's always a better idea than him having a low and then not trusting you. And then because you have to maintain that patient trust. If you switch them to something new and they have a low on it, they're unhappy about that. So yeah, I would do that for both TGO to Tresiba, I'd decrease it by 20%, and TGO to NPH, I'd decrease it 20%. I could always raise it back up later.
Yeah.
Okay. Thank you. So I just want to thank you all for you all had excellent questions today. Best of luck on the exam tomorrow. And, I think it's important, just the most important thing I can give you is that to just stay calm. Like, more important than my website is, stay calm. If you do get nervous, do some deep breaths to 7, because that's the target, and then continue on. If you have a question that you're stuck on, just skip it. Don't worry about it. It's probably a pilot question. Yeah. And Joy asked when the results come back, usually in a month. Usually you'll probably get them in July sometime. Yeah. Okay. Thank you, everyone. And best of luck on the exam.